Assalamu alaikum. Hi, I'm Dr. Iftikhar Talks. I'm Professor of Surgery in Nishta Medical University, Multan in Pakistan. On this channel, we will upload videos related to medical education and certain topics of public health. But today, I would like to tell you about how to take a good progress on your admitted patients. Well, as a junior medical doctor, you must be taking medical notes, writing them down, and you need to understand that there are basically two different types of medical notes. There are notes like clerking, operation notes, blood transfusion notes. Sometimes you have to write transfer notes. All these medical notes are just one-off things. Patient is admitted, you have to clerk him and write it down. You have to write operation note, transfusion notes, etc. But there's a special type of medical record, medical note that you have to in most hospitals do every morning. That is called daily progress. You take the progress of the patient to see how the patient has been doing in last 24 hours, write it down in some sequence and then present it in the morning round to your consultant or attending. We strongly suggest that when you write the progress of the patient, you follow a fixed pattern of SOAP, which means that you take your patient's progress in 4 distinct sections. That is, number 1, subjective, objective, assessment, and planning. So S for subjective, O for objective, A for assessment, and P for planning. These are the 4 sections you have to take the progress under. Out of these 4 sections, 3 are fairly simple and short. That is, subjective, assessment, and planning sections are usually consisting of 1, 2, 3, or max 4 lines each. But the objective section can be a bit lengthy. What we'll do is now we will try to look into each of these one by one and try to understand what they mean and how to sort of write them in a daily progress. So first of all, let's talk about the subjective part of the subjective section of the progress. Now, as the name suggests, the subjective portion of the progress actually means the patient side of story. How does the patient feel? How does he had last 24 hours? For example, if a patient had cholecystectomy the day before, you approach the patient and ask, how are you doing? The patient tells you that, well, doctor, I'm doing well, except for maybe I'm a little sore in the upper right part of my belly, but I've had some breakfast and that was okay, and I think I can go home and manage myself there. Right. Now, in this case, the patient is feeling well. All you have to write in the subjective section of the progress is that patient has had cholecystectomy yesterday. He is doing well, though he feels a little bit of soreness in upper part of his right abdomen, but he has had some breakfast this morning, which he tolerated well and feels that he can go home. Right. So this is patient side of story, and you have written it down under the subjective section of the progress. Sometimes patient side of story cannot come from the patient himself, because either the patient is confused or patient is unconscious, maybe patient is being ventilated, or sometimes because the patient is a child. So in this case, the patient side of story will be acquired from the patient's nurse or attendant or patient's parent. For example, in a child, the mother may report that the baby has been rather unwell during the night, has been running temperature, has had a couple of episodes of vomiting. So in that case, under the subjective section of the progress, you will write that the mother reports that the patient has been unwell during the night and the baby has been running fever and has had 2 episodes of vomiting. So this is simply, as you can understand, the patient side of story that you write in 2, 3, or 4 lines. Now we come on to the next section, which is the objective part of the progress. Now, as I mentioned, this is a bit lengthy, and as the subjective part was patient side of the story, the objective bit of the progress is actually the information which is actively collected by doctor himself, that is yourself, right? And this information has to be very objective, very measurable, and usually is reproducible. For example, you will mention the pulse of the patient. You can say that the heart rate of the patient is, for example, 92 per minute. Now you have exactly given a figure, right, which is measurable and which is reproducible, and other person can come and check the pulse and can sort of check the accuracy of your reading. He can come to the conclusion, yes, well, the pulse is actually around 92. So these are the three characteristics of objective part of the progress taking, that all the information that comes under this section is actively collected by the doctor. It's not patient's part of the story. It's not his side of the story. It's doctor's side of the story. So you collect the information, and this information has to be therefore very objective and measurable, and has to be reproducible. Now, under the objective section of the progress taking, there are 7 distinct components. So you have to observe and then write down 7 different things in the objective part of this progress taking. And these 7 different things are: number 1, vital signs; number 2, examination of the patient. And this is basically a focused or a relevant examination of the patient, which may or may not include examination of the wound. Then third is tubes, wires and attachments. So you note the characteristic of what is happening to the tubes, wires and any attachment coming in and out of the patient. Then any labs over the last 24 hours, any new radiology or imaging over the last 24 hours. Number 6 is that you review the drug chart of the patient, and number 7 is that you review whether there has been any result of the calls or consult that you sent for this patient to another specialty. Right? So we will sort of go through each of these 7 components one by one, try to see what does that mean and how you get this information, how do you write it down. So first of all, let's talk about vital signs. Now classically there are only 4 vital signs, as you know, that you record pulse, blood pressure, respiration and temperature of the patient, respiratory rate that is, and the temperature of the patient. But most of the people believe that in addition to these 4 classical vital signs, you also need to note the oxygen saturation of the patient as well as the pain score. Now, as far as the oxygen saturation of the patient is concerned, you know that this is recorded by pulse oximeter, which is a small probe on the finger, and it gives you the saturation of the patient, which in a normal person is around 97, 98, 99 or even 100%. So it is in high 90s. But this is not enough just to write only the figure of the saturation, that the patient is saturated 97%. It does not mean anything till you also tell that whether the patient, while the saturation is 97%, is breathing room air or is he on any supplemental oxygen as well. So this figure is not meaningful till you tell that information as well. So you have to find out, and you have to write as well, that what is the saturation and whether this is on room air or patient is using any supplemental oxygen. For example, I can tell you that if you have got a patient who has got a saturation of 89% and he is breathing room air, he is not doing well, because normal saturation is in high 90s. But this patient is miles better than another patient who has got a saturation of, for example, 91%, and he is on a supplemental oxygen of say 8 liters per minute oxygen by a face mask. Now, although 91% is better than 89%, but now this 91% is on a lot of supplemental oxygen. This patient is not as good, right? He is doing actually very badly. Okay, so therefore, whenever you write down saturation, oxygen saturation of the patient, you need to write down what is the oxygen saturation of the patient, as well as whether it is on room air or on supplemental oxygen, and if it is on supplemental oxygen, then how much supplemental oxygen. Now we go on to the 6th vital sign, which is pain score. Now pain score becomes a vital sign when you write it objectively. That is, you cannot just write, patient can report that he has pain or not, but then it goes under the subjective. If it has to come under the objective, then you have to quantify it. How much pain? Yeah, you can use a very simple score like mild, moderate or severe pain, but most people prefer that you use a scale of 0 to 10, which means that you have to educate the patient first. You approach the patient, you tell that, okay, I need to know how much pain you are feeling. So if you are feeling no pain whatsoever, tell me 0. okay, and that I have got zero pain. But if you have got some mild pain, you have got some feeling that there is some nagging there, but you don't need any medicine for it, you can say that I have got pain at the score of say 1 or 2. But if you need some mild analgesia for that pain, right, some painkiller for that, then you may say that, well, I've got a pain of maybe 3 or 4. But if you think that you need a very strong painkiller for that, you may tell that, well, your pain is of the score at 5. But if your pain is really, really bad, you have already had 1 dose of a painkiller, but it's not working, you need a second, maybe then you can say that your pain is at 6 or 7. If your pain is absolutely excruciating, you can tell that your pain is at 8. If you think that your pain is absolutely killing you and it cannot get any worse, then you can say that, well, my pain is at the level of 9 or even 10. So once the patient had understood this pain score, then he can tell you, okay, doctor, maybe I've got a mild pain. I would like maybe a couple of tablets of painkillers, but I would score my pain at 3. So you will write down that the patient's pain is at 3 by 10, that out of, on a scale of 0 to 10, the patient's pain level is at 3. Or if patient has got more pain, maybe patient's pain level is 5 by 10, or patient's pain level is 7 by 10 if it is very severe pain. Or if it is absolutely excruciating, it may be 7, 8 or 9. So this is how you score it and write it down. So to summarize the vital sign again, we note 6 things. We note the pulse, the blood pressure, respiratory rate, temperature of the patient. We mention what is the saturation of the patient, along with, that is the oxygen saturation of the patient, along with whether this saturation is on room air or patient is taking any supplemental oxygen. And finally, we write the pain score, usually using a scale of 0 to 10 pain score, right? So this is the first component of vital sign that we note in the subjective portion of the progress taking. The second portion is examination of the patient. In daily progress, we usually do not do a full examination of the patient because that is done during the clerking. We usually confine ourselves to what is called a concerned or a targeted or more or less a targeted examinations, right? Which may or may not include the examination of the wound, right? For example, in our cholecystectomy patient, when you are examining the patient, you may like to sort of look into the eyes to see if there's any tinge of jaundice, have a look at the abdomen, if it is tender, if there's any distension, what about the bowel sounds. If a patient has had, for example, operation of an inguinal hernia, you may again like to examine the abdomen and look at the inguinal-scrotal area, especially the scrotum, for any hematoma. If you're working on a medical floor and you have got a cardiac patient, you may like to have a look at the neck veins, whether they're engorged, look at for the pedal edema, auscultate the chest, whether there are any basal cracks or not, etc., etc. So you do a targeted, a relevant examination, and if you're on a surgical floor, you may like to sort of examine the wound as well. Sometimes surgeons don't like the wound to be disturbed too often, right? But if you do examine the wound, then please do mention its characteristic. For example, you can say that wound is okay, or you can say that wound looks inflamed, or you can say that the wound is generally healthy, but the third stitch from the top looks infected, or there is a blood oozing from the wound. So whatever your finding is, you have to mention it, right? So this is the second component of the objective portion of history taking. So first was vital signs, then you look at the relevant examination bit. The third thing is the tubes, wires and attachment. So you have to look at all the tubes, wires and attachment coming into or leaving the patient. For example, you may have to, you would like to look at the IV lines that is going in, what sort of fluid is running, how much fluid patient received over last 24 hours, what were the different infusions, nutrition, etc. Similarly, you look at the tubes that are coming out. For example, what is the status of the nasogastric tube, Foley's that has been inserted for urinary calculation, any abdominal or chest drains. So you have to note not only the quantity of fluid coming out, you need to look at the quality as well. To give you an example of the same cholecystectomy patient, if the patient's cholecystectomy was a little difficult and the section was tedious, then surgeon may decide to insert a drain at the end of the procedure. When you come in the morning, for example, You look at the drain and you find, well, okay, there's 40-50 ml of a serous straw-colored fluid with some tinge of blood in it. Then you won't be worried. I mean, it is expected that after a difficult cholecystectomy, you may have 30-40-50 ml of serosanguinous fluid. But if that 50 ml of fluid is actually bile, well, this will make you very worried, because this either means that there has been a cystic duct has been has lost its clip maybe, or there has been injury to the common bile duct, or still worse, maybe there's a duodenal injury. So that is why you need to look at all the tubes, the amount of fluid coming out, any, for example, in case of chest drain, any air coming out, right, bubbling through the chest bottles, and what is the quality of the fluid coming out as well. In addition to that, there may be other things as well coming out of the patient or attached to the patient, like wires. For example, if you are working in a cardiology ward, a patient may have pacemaker wires, right? Then in that case, you have to look at the pacemaker box, see if the pacemaker box is working okay, it is producing the impulse whenever is required, and the other parameters and criteria that you have to look at. There may be other attachments, other monitoring devices connected, splints and other things. You have to practically look at everything and glean the information that is necessary, that is important for decision making on that patient on that very day. So this was a third. So first thing in the objective section of the history taking, progress taking was vital signs. The second thing that I mentioned to you was the relevant examination, and the third thing was tubes, wires and attachment. After that, you look at the fourth thing, which are the lab results. Any lab results which have been now become available in the last 24 hours, you need to look at that and compare it with the previous results. You especially need to look at the trends. For example, if there's a suspicion that patient is bleeding internally, you need to very carefully look at how the hemoglobin and the hematocrit is going. If they are both have got a sort of a falling trend, well, maybe the patient is bleeding internally. Similarly, if patient has got infection, you may like to look at the white cell count, or in a renally impaired patient, you need to look regularly on a daily or even more frequent basis on electrolytes and renal parameters. In a diabetic patient, we have to look at the blood sugar levels, where they are going, how much insulin is required, does the patient require extra doses of insulin, etc. So after you have done the labs, then you need to check at the radiology, whether any new X-ray has been done, any CT scan or any CT or MRI done previously has been now reported. So you have to look at those and collect all the information to be presented in the morning round then, right? Next thing you do is you review the patient's drug chart. Look what drugs, medicines patient is receiving. Has any drug been crossed off in the last 24 hours, or any new drug has been added, or any doses that have been changed, or did the patient require extra doses of, say, for example, extra unit of insulin to keep the blood sugar level within reasonable level, or patient who has been having seizure, how many anticonvulsant top-ups he has required, etc. All this information is required of you in the morning round to make the decisions, right? And doing that, the last and the seventh component, final component of objective progress taking is that you look at the response of calls and consult that you send to other departments about this patient. What happens that you may have to ask for the expertise of other department to come and help with your patient, right? So if you have written a consult, you need to see whether they have seen the patient and sent a response. You need to then see that response and pass this information onward to your consultant in the morning round again. So these two has to go under the objective progress taking. So if we recapitulate it all, after finding out the subjective part of the progress taking, which is basically the patient side of story, you do the objective part of the progress taking, which is actually the facts and figures and the information and the numbers that you as a doctor find out, right? And you do it under 7 well categorized components. Number 1, you record the vital signs. Then you do the relevant examination, which may include the examination of the wound. Then you look at all the tubes, wires and attachment and make the all relevant observation and note them down. You look at all the new information that lab has made available in the last 24 hours, any new radiology and imaging that has come across, and look at the drug chart, what has been the changes, has there been any addition, any deletions, and finally look at the consults. Have you sent any consult to other specialties about this patient? For example, if you are on a medical floor and you have a patient for control of diabetes, but you sent a consult to surgical unit because he had a bad wound on the foot. So you need to see that I sent the consult yesterday. Has the surgeon seen the patient? And if he has seen that, what he has said, has he added a new medicine? Has he advised that patient needs debridement or maybe even an amputation? You need to be armed with this information for the morning round and be ready when your senior doctor asks you to pass this information on so that appropriate decision can be made about this patient. Now, once you have completed your subjective bit of progress taking and the objective bit, the subjective being the patient side of story and objective is the information that you actually elicited, now you combine these two bits together to reach a conclusion that how your patient is doing. Right? Now this component, again, as I mentioned, is usually very small. It consists of 1 to 3 lines, right? For example, in the cholecystectomy patient, where the patient is actually, except for a little soreness, is okay and actually has tolerated breakfast okay, all you may have to write is that, well, this is a patient who underwent lap chole yesterday. He is doing well, except that he is a bit sore in the right upper part of his belly. He has already taken his breakfast and is tolerated it well and is of the opinion that he is good to go home. So this is your assessment. So your assessment would be the patient is good and is ready for discharge. Okay? So this is how you make the assessment. So you combine the information of subjective and the objective component of the progress taking and then come to a conclusion. Similarly, if the patient, there is a patient who underwent laparotomy the day before for maybe a road traffic accident, but now you suspect that the patient is not doing well because his pulse is rising, blood pressure is falling, the urine output is not great, and on serial examination the hemoglobin and hematocrit are falling, and in one of the abdominal drain you have just noticed that 350 ml of blood has come out. So your assessment may be the patient is deteriorating, he is not doing well and is probably bleeding internally. That is your assessment. Or in case of maybe a head injury patient, your assessment may be that patient is not doing well because his GCS has deteriorated from 14 to 12 and may be developing an intracranial hematoma. So you see that assessment again is a 2, 3 or 4 max 4 liner. But this is actually a combination of information from subjective and objective component. When you combine them together, you reach this conclusion, and this is the assessment. Now, armed with this assessment, you go to the fourth section of the progress taking, which is plan. Now you have to make a plan for this patient, depending on your assessment, that what do you want to do with this patient. For example, in a cholecystectomy patient who is doing well, your plan may be that patient is well and can be discharged home on mild analgesia. But in the other patient who underwent laparotomy for road traffic accident and now is suspected that he is having internal hemorrhage, your plan may be quite different. Your plan may be that, okay, I will start an IV resuscitation plan and I'll send all the labs fresh, alert the blood bank, and I'll inform my seniors, and patient may be needing re-exploration. So see, these are two very, very different plans for two different patients. Now, with these 4 sections of subjective, objective, assessment and plan, you have written down your progress for this patient. But this is your progress, this is your assessment, and this is your plan, and you are a junior doctor. Right? You are still in the learning phase. So there is a possibility that despite your best efforts, you might not have reached the right assessment and not made the right plans. That is why there is a hierarchy. That is why there are senior doctors who go around with you in the morning. And this is why most of the time the most of the hospitals have this arrangement that you take this type of a progress, write it down, right, and then present in the morning round to your consultant or attending and get their opinion, how they think about it. Well, this is how you think about the patient, but what they think about the patient. So after listening to you, most of the time what will happen that your senior doctor, who is usually your consultant or your attending, will sort of analyze all the information. Maybe he will examine certain bit of patient again, maybe he will look at the labs again, reconfirm some of the findings, utilize his experience, utilize his clinical acumen, and will come up with an opinion. Now this is his opinion, and this is very important. So at the end of the daily progress, after completing your 4 component of subjective, objective assessment and plan, you write down patient seen by, for example, Professor Wiseman, and he has advised, and then you write down his advice. Now his advice may be exactly similar to your plan. For example, he may agree in the cholecystectomy patient and tell you that the patient is well and can be discharged home on mild analgesia. So you will write down that patient seen, and you will write down after your progress, right? After completing your 4 component, that is subjective, objective, assessment and plan, you will write down that patient seen by Professor Wiseman, and he has advised that patient should be discharged on mild analgesia, right? But in another patient, right, the professor may disagree with you. He may have entirely different idea, and his advice may be entirely different from your plan. Now this is the magic of progress taking and of learning, right? And you will very soon see that although this whole exercise of progress taking is useful in patient care as well, but the biggest beneficiary of this exercise is you. It is for your learning. It is for your training. You train your mind how to talk to patient, how to look at the patient, how to glean information, the subjective information from the patient and the objective information that you have to look at various tubes, vital signs, etc., look at the labs, and then finally make an assessment and then formulate a plan. This provides you the brilliant opportunity of making your own mental exercise, making your own plan, and then presenting your plan to your senior, who will be a very senior person in the hierarchy, and then get his advice and then compare your plan with his advice. Sometimes they will match, which is lucky, and sometimes they won't. So don't worry, because that is why you are here in the training. That is why you are doing your residency, to learn, right? To bridge this gap. So initially during your training, you will note that your plan will differ quite significant maybe from the advice given by your consultant or attending. But as your training, as your residency will progress, you will see that you will learn more and more, gain more experience, accumulate more acumen, and very soon your plan will start falling in line with the advice given by the professor or your consultant or your attending. That is how you become a very senior doctor yourself, and hopefully a consultant and attending and a professor yourself in due time, right? So I hope you like this and you understood how to take a good progress, and this will benefit you a lot if you follow this pattern. Now all this information that I have given to you is also available in my book, which has a title, House Job Guide, right? The full title is House Job Guide, Surviving Clinical Infancy. In Pakistan, it is published by Paramount Publishers, and it is freely available in the market, especially in the medical bookshops. In addition to progress taking, it has many other very interesting topics in it, which are described in a very easy style. We have chosen those topics which are considered to be difficult to understand. They are not clearly usually written and described in our standard clinical textbooks. They are not taught either in a very structured way, but as soon as you enter your training program or your residency, everybody expects you to know everything about that, right? So what we have done is we have collected all those nearly 20 topics, right, and written about it in a very easy style for you to understand. These topics includes things like conducting ward round, taking progress, for example, writing a prescription, sample handling, blood product and their use, consent, breaking bad news, communication skills for the doctor, career advice, sutures and needles, theatre etiquettes, that is operating theatre etiquettes, basic interpretation of ECG, basic interpretation of blood gas reports, basics of mechanical ventilation, etc., etc. We will give on your screen a shot of the content page of my book, right, which is again titled House Job Guide, Surviving the Clinical Infancy. We wish you a very happy learning experience with it, and we hope that you will join us in our new video as well. We'll again welcome you then. Thank you very much.